Good morning, Don here. Welcome to Podiatry Practice Mastery, where we're helping you get your practice to the $1,000,000 mark and beyond. I want to talk a little bit. I'd like to know what your opinion is. It's kind of a funny question, but does anyone else do really slow injections for toe blocks? The reason I'm asking this, I have a colleague here that started it, and he says, "Yeah, Don, I always take like a whole minute or I don't know, a minute and a half to inject a toe because it doesn't hurt as much." So they kind of have it numb up as they put it in and do it that way. I knew another doctor that he had this little device that kind of it was almost like an air gun that shot a little bit of to numb up the skin. Some people use cold spray. I sometimes find that cold spray is actually more problematic. So I'd like to know if anyone else does really slow injections so it doesn't hurt, or if they have any other way to make ingrown toenails or anything we numb up not painful. The reason I was thinking about this is because I think like my main offer right now is speed. So urgent care visits within 24 to 48 hours. I think that's a good offer. But I think another offer we could almost have, and I got this from another doctor that talked about she advertises ingrown toenails. I was thinking, if you could advertise like a pain-free ingrown toenail procedure, I think that would do well because that's what most patients' big concern is. So if you have any good tips for me, shoot me an email, don@podiatrypracticemastery.com. I'd love to know what you are doing for your ingrown toenails to make them pain-free. I was recently excited. Actually, I did a podcast interview yesterday for another podcast. So if you like this podcast, you might like other podcasts. And this one's called Podiatry Marketing. It's with Tyson and Jim McDonald. And it was a fun time. It was actually so much fun. I couldn't even sleep last night. Not just because probably because it was a late night interview. I don't tend to do interviews or podcasts late at night. It started at 9 p.m. and I was like so excited about talking about different things. But one thing Tyson told me that I didn't really gather. I feel like I'm having a struggle with traction on this podcast. Meaning, because there's been so many episodes, and I find that there's very few listeners to it, and I'm not sure why. And I don't know if it's the quality of the podcast, but what I'm thinking is, I think in our training, there's not many entrepreneurs, and I think a lot of the young doctors are more interested in maybe instead of practice management and increasing revenue, they're more interested in maybe surgery and other things like that. And I think if you are in a busy practice, there's no need to really grow your own. You're just you're fed patients. But I'd like to know your opinion. If you think that is the case, what Tyson recommended, he said, Don, you like to talk about Shockwave. So what you would do is you would do like a course or a master class on Shockwave, like teaching how to use Shockwave. And then within the course, you would talk about the practice management. So a lot of, maybe if you're not in this marketing mindset, you might think like, oh, Don talking about how to get to the $1,000,000 mark is dirty. Like he's doing something illegal or he's doing something unethical. And really it's the opposite. It's just being smart about how we do things in the practice to get there, and not even anything about, anything like negative or unethical. On the contrary, I think it's being very ethical, everything that I talk about here. So I'd just like to know if that's like off-putting to some people, like always talking about the finances, and that might be because people are more employees now and versus owning their own clinics. Okay, that was my little rant today. I'm going to go over some patients here that we saw. So first patient was a 36-year-old man. He's preparing for a marathon. He has bilateral non-insertional Achilles tendonitis. So he has the bulbous changes. He's had it for a long time. He struggles with navigating stairs. Really kind of too young for this. And when he's a couch potato or doesn't do much activity, he doesn't have much pain. But when he is running and things like that, he has this pain. So I went through my treatment sheet. Once again, if you don't have my treatment sheets, if you'd like them, just send me an email. don@podiatrypracticemastery.com. I'll send you mine. Some people have been requesting them. I went over the treatment sheet. He's going to do the initial night splint foam rolling morning stretch. Because it's bilateral, he could get bilateral night splints. So this is a kind of a smart thing to do for your practice, because you can do bilateral DME. And he's also going to be, once he starts that, I'm going to see him back, and then he's also going to do bilateral shockwave, so doing 6 sessions. So when I explain this on my treatment sheet, the first thing I talk about is shockwave, and I say you might want to try some of these other things first, or if you really want to do what works, shockwave is what works, because I truly believe that's what works for non-insertional Achilles. And so he set up for all 6 sessions. So this would probably be my MVP, my most valuable patient of the day, because that bilateral shockwave is probably going to be about 3,000. Then it's a lot of visits, right? It's about 6 visits coming in to see me, but I find it works pretty predictably. I would say probably 85 to 90% of the time, patients get better with this. I haven't really had many that haven't. And also during my explanation, I talk about amnio, and I say amnio might be necessary. And so when we're talking about amnio, the price for amnio, like PRP and things like that, for us is $1,500. So that use of that higher amount is something that's called price anchoring. So you can always talk about something that's a lot higher. I don't do a lot of amnio, but I use it more as an anchor price to make the shockwave seem less expensive. So this is kind of an advanced kind of a way of talking about marketing. And really what depends, it's the ultrasound. So the next visit, I'm going to plan on doing bilateral ultrasounds. If there is certainly a frank tear in there, then I will offer the amnio in there. I usually do the amnio at the 2nd visit, and then if needed, I do orthotics at the 3rd visit. Okay, so this is just kind of a advanced technique. I don't know if this works for anyone else or if anyone else does this type of thing where I offer amnio much of the time, but very rarely am I actually doing amnio. You could do that for any other things. You could talk about surgery. You could talk about other things that patients don't want, and it makes the other thing seem a lot more beneficial. Okay, that was the first patient. Second patient was an 82-year-old female. She almost didn't come back to me because of how painful her last hallux injection was. And so I tried to do a really slow injection. So I did not use cold spray. I just went really, really slow. It took me, it felt like forever, but I think it was like maybe a minute to numb up the toe, but she had no pain. And I'd really never done that before, and it seems really obvious, but I'm trying to go slow. So I think maybe that extra time, or if anyone has a better way of making it non-painful, that would be great. She had a matrixectomy, and so I did this matrixectomy for this patient today. She also had. I'm sorry. This is a different one. Sorry, that was a matrixectomy. This patient actually had a painful met cuneiform joint, first tarsal metatarsal joint pain, and I did a cortisone injection for this one under ultrasound guidance, and I also gave her a cam boot, and actually did not give her a cam boot because she got one from the ReadyMed, which is urgent care around here, so no cam boot, but I did that joint injection, and I think this patient was actually, they said they did it under fluoro, but I'm thinking they may have missed the joint. That's what I'm thinking. That's happened to me as well. Even with ultrasound, I sometimes can miss the joint. A little bit less now with ultrasound, missing the joint. Next was one of my favorite procedures. This is a exostectomy. So dorsal medial hallux had a kind of a painful exostosis with a callus, kind of an overlapping second toe. Actually, dorsal lateral hallux. And that callus there, I trimmed down the callus multiple times, still was bothering her, so I took a little 15 blade, made an incision, and shaved down with a rasp right in the office. So this is a very good procedure, reimburses quite well. This was planned, so there's no office visit for this one because they had come in for the actual procedure because there's no decision making, and we did a rasp right in the office. So this is if I could do this type of procedure and flexor tenotomies and these small little procedures in the office, I would do them all day. Next was a 41-year-old female. She caught her 5th toe on a bed, and she had a fracture at the base of the proximal phalanx. Put her in a cam boot. Used a fracture code for fracture treatment code. So that means there's a 90-day window. I'm going to see her back in 4 weeks. I can't do any more office visits for that. There was another patient, 83-year-old female. She also had a first met cuneiform joint pain. I did an injection with cortisone for her and a cam boot as well. because it was quite painful. Next was a 55-year-old female. She had right plantar fasciitis, and she was going on a hiking trip, and she didn't want to be in pain. I did an ultrasound, showed her the thickness, and I did a cortisone injection. I don't do a lot of cortisone injections for plantar fasciitis, but when people are going on vacations or they have a special event coming up like a wedding, I will do it. And then I prefaced her that most likely the pain would come back in a couple of months, and when that happens, the next step would be the shockwave because I think it works better. So I kind of teed her up for the shockwave. And something that when I've been explaining shockwave, I tend not to shy away from the price, and actually tend to really tell patients, the shockwave is very expensive, and I kind of explain it that way these days. I think in the past I used to always shy away, almost apologetically, saying, shockwave is expensive, but it works. But now I tend to tell patients, this is very expensive, but I say, but it really works, and this is certainly what I would do and what I do. I wonder if you should say do on a podcast, probably not, but and I say that, so this is very expensive. It's like $1,500, or if it's bilateral, it's $3,000. And it can even be more expensive if I do amnio, which is going to be another $1,500. But most people don't need that. So, and I just kind of explain it that way for patients. And so I prepped that patient. Next was a 36-year-old female for an MRI of the left foot. She is feeling better, so no follow-up, but I did review the MRI. Next was a 39-year-old female that had a left dorsal cyst on the foot. But it was near the area of the first metcuneiform region. Actually, no, it was the metcuboid region, and maybe the extensor tendons. But I'm not sure if it was a cyst or not. There was like a dark brown lesion there. She doesn't remember having a cyst, but it kind of feels indurated like a cyst. So the plan for her is I didn't have time to do it, so I'm going to see her back in 2 weeks to do a punch biopsy on that, just to make sure it's not anything else because of the dark discoloration of it, nothing like a melanoma or anything like that. And then she also had these really kind of dystrophic nails that were only attached down to like the proximal 1/3 of the nail, and they weren't attached distally, so they're like an onycholytic nail as it grows out. So I put Onifix bilaterally on that patient, and then we're going to see her back for the biopsy. So the Onifix, usually I don't see people back for that. I just see it back when it comes back, when it falls off, and I guarantee it'll last for 3 months. If it doesn't, then I will put it on again with only charging an office visit. So the Onifix reimbursed quite well, I think, for the amount of time. Onifix is pretty easy to do, so I charge $125 for the first nail and $75 for the second, and then we'll do that biopsy, and we have the office visit for her. Next was a 64-year-old female for a left bunion, and she also had a flat foot, more so on the left side. So for her, we did an orthotic, and on the left foot, she had pain to the sinus tarsi. And she was thinking it was all caused by her bunion, but her bunion didn't hurt at all. So we talked about anatomic shoes and things like that, and then we did a cortisone injection in the sinus tarsi for her, and then I also scanned her for orthotics, and she'll be seen back when the orthotics come in. Next was a 46-year-old. She had follow-up on Onifix. Actually, she had and I did a nail sample for possible fungus. So I'm gonna see her back for that. She had Onifix on the great toe, and actually the toenail is clearing out and looking good for her that she had in the past, but she's still concerned about nail fungus. So we did a nail sample, and now this one, because I was busy in this, I want to explain something. So when I'm towards the end of the morning, I tend to have like meetings around 12:30, so I want to get done. So in this case, instead of starting her on the whole nail process right away, I said, well, I'm going to do a nail sample. I'm going to see you back in 2 to 3 weeks, go over the results, and then we're going to start that process. So a lot of times when I treat patients, it's based on how much time I have or how much time I want to invest. I tend to like to do everything the first day, like the ultrasound, even starting shockwave if I can, going through my whole nail process. But if I'm running late, a lot of times I make it so that they'll do the sample and then they'll come back to go over the results, and we can do the whole nail fungus treatment process at that time. I try not to what I used to call like milking for visits, like having them come back just for for no reason or for a very limited reason, because I think that patients didn't like that due to their higher copays. That was the morning. Afternoon, a 75-year-old female, she had just nails and PVD, so she'll come back on my nail care day on Friday mornings. A 77-year-old man for left posterior tibial tendonitis. Got x-ray, got an ultrasound showing effusion around the posterior tibial tendon, and he also set up for 6 sessions of shockwave. So I did not do the first one. He's going to set those up. He needs to look in his schedule. So that was the second set of shockwave that were set up. Next was a 46-year-old female for, she had a cyst. I did x-rays, ultrasound, and I aspirated that cyst, and I put Coban around that cyst. She's going to come back as needed when it comes, if it comes back. And we do sell a lot of the things that patients need at the front desk. So we have 1-inch Coban, 3-inch Coban, and then tape. For like taping down, for like if there's a bulbous change at the tip of the toenail, that skin, where they can do T-taping, I call it, with like a fabric tape. We keep it pretty reasonable. It's just easier than going to the pharmacy for those things. Next was a 42-year-old female for posterior tibial tendonitis, number 1 out of 6 for her shockwave. Next was a 78-year-old man. He had callus care. He had a hammer toe that was kind of twisted, that causing that callus. Did an office visit for the hammer toe, and I did the callus trimming for this patient. Next was a 5-year-old little boy for right canthal tendon to the right heel. Next was a 52-year-old female. This is a hard one. I'd like to know if anyone has any good treatments for this. She had lymphedema, or I've had some patients called lipedema. So I think lymphedema is like lymph, lip is like fat, and so sometimes not even that heavy. It's usually females for some reason, what I see. They're not very heavy, but they have like all this fat deposition in their legs. And she came in because she just had she didn't want to wear sandals. She had all this kind of fat around her ankles. And I don't know if it's fat or lymph or whatever it is. So I talked to her about anatomic shoes. And then she also had a nail that was thickened. So I gave her some, there's some PTs that specialize in lymphedema. And I took a nail sample for her nail fungus, so I'm going to see her back in 3 weeks. So I don't really have any great treatments. I've tried some of these compression, I don't know if they're like big things you put on their legs, and they kind of do segmental compression, pushing up this stuff. But I don't have any really great treatments. I don't know if anyone else does. If you do, let me know. I'll share it with everyone else. And the last patient of the day, this was a 45-year-old female, number 3 out of 6 for shockwave for the plantar fascia on the left. And she asked me to scan her for orthotics. So let me explain how this happens. When I present shockwave for patients, I always tell them when they're having plantar fasciitis, I don't think any shoe really feels good. Even if they get like a maybe Hoka's or whatever they're going to buy as like an athletic shoe, a running shoe. It might feel okay. I think UFOs feel good. But I tell patients, if your plantar fascia is inflamed, I don't think any shoe is going to really feel good, or any orthotic or any insert. And so when I do orthotics is not like at the first visit, because by the 3-week third shockwave, they're still going to be in pain. So I tend to do orthotics at the 3rd visit, so that at the last shockwave visit, which is the 6th visit, they get the orthotics. And then they might start to be able to tolerate it. But if they can't tolerate the orthotic, and it's only on one foot, it's because the foot's hurting. It's not because of the orthotic. I think there are a lot of patients that get concerned. They're like, this thing isn't comfortable. Well, I ask them, well, how's the other foot? Oh, they say the other foot's feeling fine. Well, the problem isn't the orthotic, it's your foot. Your foot's not better yet, and it can't accommodate the orthotic. I think the orthotic works better later on to help reduce the strain on the tissues in there once they are feeling better. So that is something that I discuss that with patients. But this is orthotic number 2 for the day for this patient. So that was the day. Once again, hope you guys found this beneficial. When I was talking to the other guys on their podcast, I was just reminiscing to something that really kind of brings joy, and I feel like I can give a lot of value. So if you are interested in coming to visit my office, I've offered this before in the past, shoot me an email, don@podiatrypracticemastery.com. I'd love to have you to come and visit. If I'm too far away and you know other doctors in the community that are business savvy and things like that, go visit them. I think something that was kind of underutilized by practicing doctors and more so even by residents is visiting other doctors. As I was on the podcast, I was reminiscing when I was in residency. Afterwards, they started a new rule that you had like to be at the hospital certain hours, because I was always at my attending's offices, because I knew that if I wanted to, like the surgical thing I was going to learn with the cases, but like all the other business acumen and how to talk to patients and how to explain things, that's where you learn in private offices. And so I'm a big advocate of spending time in private offices with doctors that are better than you, and better in, there's multiple ways, right? Could be better at surgery, could be better at practice management, could be better at just talking to patients. And so whenever I went, I always learned like what to do from some doctors, and I learned what not to do with other doctors. But being in people's offices, I think you can learn much more even than listening to like a podcast or going to a conference. It's spending time with other doctors, whatever specialty it might be. It might not always be podiatry. So I think spending some time, like taking some time out of your schedule, a couple times a year, go visit someone, and I'm willing to receive you in my clinic. Just schedule a day, but that would be a lot of fun. And I've thought about one of my big complaints about on that podcast as I was ranting. I was saying, I want to help people and I try to give all of this, but I find giving it for free, people don't value it. So that's why I have to charge for like my Practice Mastery Academy. That's why I have to charge for the mastermind, for the coaching and things like that, because I think that if it's not charged, people don't really see the value in it. So I'm certainly willing to help, but it's frustrating, right? Because people aren't willing to change unless you charge, so that's why I have to kind of charge for things. That's the reason I do it. It's not so much for the money, it's more for it'll make people much more motivated, because I know that when I pay for things, when I pay for my coaching that I go to and other types of events, I pay more attention and I get more value out of it. If you don't pay, you don't give value to it. You don't kind of do what you have to do. Anyway, that is my rant for today. Hope you guys found it beneficial, and we'll talk to you tomorrow.